Hello, everyone. Welcome. So my name is Jen Braun, and I direct the AHA Team Training Program. Welcome to today's sponsored webinar, An Improved Standard of Care, the Effects of Social and Behavioral Factors on Maternal Mortality and Morbidity. We're extremely honored to have Relias sponsor and lead this presentation and discussion today. But before we get started, just a few rules of engagement to highlight. By now, I'm sure many of you are familiar with Zoom, but just to point out a few reminders, you can access audio by listening in through your computer speakers or through your phone. And please note that everyone is in a listen-only mode. So if you're having any audio issues, you should be able to access the toolbar at the bottom to switch to either phone audio or computer audio. This webinar is being recorded and will be made available on our website. And so throughout the webinar today, if you have questions for our speakers, please enter them in the Q&A pod, which you can find on the bottom of your screen. I will do a moderated Q&A session at the end with our panelists and speakers today. If you have any technical issues or questions or any comments in general, feel free to use the chat pod. And please note that all participants on the webinar can view your chat. And so finally, when our webinar is over today, we'll have an evaluation that will automatically pop up on your browser. So we really value your feedback if you wouldn't mind taking a moment to complete that. So that's enough of me and my housekeeping announcements. I'll be back on to do our Q&A at the end. So for now, I'd like to kick it off and introduce our first speaker, Laura. So Laura, the floor is yours.
Excellent. Thank you so much, Jen, and we're really happy to be here. My name is Laura Sparkman. I'm a partner at Relias and a clinician by background. Really, what I do is support our clients in achieving and moving towards high reliability and improvement. That's really my background and expertise. I've been involved in patient safety and high reliability for well over 20 years. Prior to being with Relias, I was at Ascension Health at the system office, where I had a role of supporting all of our hospitals, and I led patient safety initiatives like perinatal safety, hospital-acquired conditions, core measures, etc. But we had a lot of success in creating a community across 62 delivery hospitals on improving perinatal outcomes and reducing risk. So that's really kind of the focus of the topic today. But I'd like to turn it over to my colleague, Rola, to introduce herself.
Thanks, Laura. Hello, everyone. I'm Dr. Rolamar. I'm a principal consultant for behavioral health at Relias. I'm a clinician by training, just like Laura. My background is in behavioral health care. My PhD is in marriage and family therapy, and I've spent years in integrated care settings, from hospitals to primary care, to FQHCs, to schools, and specialty care. So I have a lot of experience in, living in both the medical and behavioral health worlds as a behavioral health clinician. This is a topic that is particularly important to me because talking about factors related to mortality and morbidity as they connect to behavioral health is truly a passion of mine. And, at Relias, a big part of my role is getting to work with organizations around practice improvement and quality improvement and making sure that they're working to achieve patient outcomes, the highest standards of patient outcomes. And so I'm honored to be here and share the virtual stage with Laura, and can't wait to hear some of your questions later.
Excellent, Rola. Thank you. I do want to say, too, this is really exciting for us as an organization, Relias, because we do have this team that's focused on acute care and this team that is focused on behavioral health and community care. And even within our own organization, we recognize the opportunity to come together on this very important topic. And that's really what we're going to dive into. So hopefully you're going to hear some things that you haven't heard, and we're going to poke the bear a little bit, if you will, and challenge some of our thinking, because we are all about moving towards improvement. So today, what we want to cover This is agenda, and you'll see it's very aligned with the learning objectives, but we're going to talk about um, findings on the maternal mental health, social determinants, and racial disparities, understanding peripartum depression, and discuss screening standards and the reality of screening data and actions to consider when adopting new practices and extending capabilities. I wanted to kind of set the context here and just one of the, I call it the amazing career that I've had of being a nurse for over 30 years. I've had some time in the acute care field. I've been on the payer side for two very large payer organizations, and I've actually done case management. But for the last part of my career, really dove into improvement. And so taking all of that collective learning over time, what we know is that acute care has had a very heavy focus on what happens at that acute care time. It's a complex environment. It's actually a high hazard area of care. OB in particular is considered ICU type level care, despite the fact that, I was just at a conference last week and we had this question, what's the most dangerous thing about OB? And it's that the majority of cases are air quote normal. So we're always managing that, acute area, but we know that acute care is very focused on clinical protocols, reduction in practice variation, but now we really do need to expand to that holistic view, including clinical and behavioral. So it's not that we would ever move past what we need to do on the clinical side. And those are the things like hemorrhage, hypertension, prolapse core, you name it, sepsis. We will always still continue to focus on those medical emergencies for the OB patient, but now we have new data that is directing us to expand our view, and that's really what this conversation is about. The next piece, I just want to set this up. We have a video for you, and I had the opportunity to work with the BBC and the International Council of Nursing. They asked me to do a story with them, and this is Roll is obviously very committed and passionate about it, and we are as an organization, and I am personally as well. And so as you see the story, a component of high reliability is we share stories. We try to personalize the statistics of what happens. So I'm going to go ahead and move forward, and you're going to hear this video.
My name is Laura Sparkman. I have a very long career in nursing, 37 years. I started out as a general nurse, surgical floor. I moved from there to a cardiac intensive care unit, and I learned a lot about the intensity of patient care and the role of the nurse at those very critical moments when a patient is their most vulnerable. My family experienced a tragedy where we lost a family member, Brian, to complications of postpartum depression. So before Brian got pregnant, she had a very successful career in real estate. She was very social, loved to go to the beach, loved to shop. She was very vibrant and fun and really a delightful, lovely person. And she met Slade at a local restaurant. Slade and Brian talked about they were going to get married. But she became pregnant. She actually had like a little anxiety before she got pregnant, but she had a beautiful pregnancy. She was glowing, and she had a 10-pound baby boy, Andy Mack. Days, hours, it seemed like after she delivered her son, you could just see her anxieties and fears really starting to surface. I started to just notice how much she had been drinking. Other family members saw her drinking early in the morning. And that kind of blew up. She also didn't like being alone. She was anxious being around family. Her moods would swing significantly. We were all very alarmed. She just seemed to sound less capable of handling kind of everyday things of what it was like to take care of a baby. And it seemed like things really started to spiral. I got a call in the middle of the night. She said, Brian is in the hospital. She's in and out of consciousness. And in my mind, I was thinking, okay, well, maybe this is an opportunity, like a kind of a wake-up call where she actually is going to maybe detox and they'll get her the professional help that she needs. But it ended up being something very, very, very different. And then the next call we got, he said, I'm very sorry, we've tried to do everything we can, and Brian didn't make it. She died just shy of 2 years after she delivered her baby. So like in this picture, she looks just so happy and excited. I'm ready to have this baby, smiling.
Looking back, there's a stark difference between her presence almost.
And it can happen, actually. You're like something
Changed completely.
plus, you know, what's
Yeah, it was
the
almost-
reality of having a baby. You're
Yes.
like, oh my gosh.
Yeah, and I think in the delivery room too, I think it was such, like you said, 36 hours of labor. I think it was almost the relief of being done, but then like, oh my gosh, what do I do now?
Yeah, well,
Yeah,
that,
like
like we
she
said, all
just
that,
kind of like was out of like just not in the moment maybe,
well, all
and
that
just kind of
intent,
taking it all in.
and then all that anticipation and doubt becomes real
Yeah,
after birth.
yeah. I do like this one. I don't know why. It's one of my favorites though, because she did duck face, and then Andy learned duck face.
Absolutely. Andy, can you do duck face?
Show me duck face. Yeah, baby.
Over the years, my role really kind of morphed from, you know, being definitely a bedside nurse delivering care to one that was more behind the scenes. I work for Relias, and Relias is a software education company building quality patient safety and improving competency and proficiency in bedside clinicians. A great opportunity that I had was to lead a huge research project around how to improve quality care, and we put forth our perinatal safety program. In 2015, an article came out that really reported for the first time on a national level that the maternal mortality rates in the U.S. were worse than any first world developed country. That was shocking to a lot of people, even people in healthcare. We know that certain populations, their trend of death is around obstetric hemorrhage and preeclampsia or hypertension disorders in pregnancy, and other women have to do with behavioral health issues around depression, anxiety, and more substance abuse. It really helped me broaden my thinking about what is the data telling us about women who are diagnosed with depression or not diagnosed with depression but actually have it, and how does that impact their life when they go home after they have their baby. We're also discovering that social determinants of health, race, bias, discrimination, resources all play into that. So the research that we are doing, we think that that's going to tell us there's a big opportunity to create education for the full care team, reduce bias in healthcare, raise awareness about how important it is, the role of the nurse at that time of discharge, that they could actually be saving a life. Brian's story has really inspired me to really understand the prevalence of peripartum depression, and by sharing this story, if we save one life for a struggling mom or help a mom seek help, I think that's a great legacy for Brian.
So just to transition from that, again, we have a big opportunity. It's one story in hundreds of thousands of stories across the country where we have an opportunity to make a difference. I've just dropped a few slides in here that talks about who Relias is and all the areas that we cover across the continuum. That's really going to just be there for your reference. What I really wanted to talk about, and then you heard in the story we have as a country been very focused on the clinical aspects of maternal morbidity and mortality. But with the latest Maternal Mortality Review Committee work and the reports that are coming out, we now actually have some actionable data that we can speak to. You heard me mention the journal article in the Lancet that really did kind of bring to the forefront. And then there were several other public facing articles and stories that started following that in the years to come around various stories of women that died that should not have died in the hospital. There were several glaring opportunities to interrupt the cycle of harm, but it just didn't happen. And we know that education and teamwork and communication makes a difference. So again, you can just see the timeline here, and then here we are today in 2022, and the MMRC data. Even just last week, a new report came out on data around suicide and homicide in moms, and I didn't have the opportunity to update the slide, but I am going to put a new mile marker here for 2022, and there's more opportunity, and we're getting more clarity on where to focus and how to focus. And I even had a friend text me this morning that said, "Good Morning America," actually had a story. And again, we're talking, their viewership is in the multi-millions about maternal mortality and the disparities in care. So we're very happy, number one, that it's, making the big headlines, because awareness and even understanding that we have a problem is the first step to reviewing where we are and what we can do about it. Again, I'm going to go run through some statistics just to bring everybody up to speed. If you haven't seen these statistics, this is the type of information that's coming out of the Maternal Mortality Review Committee report. Clearly, the US has the highest maternal mortality rate. Even in COVID, it continued to stay the same. And other countries actually who were stable are also starting to see an uptick as well. So I think everybody's been impacted by COVID, but it was not a good picture even before then. As you had already heard me say, we know that Black women were 3 times more likely to die than white women in our data set in North America. And you can see, the cohorts are non-Hispanic white, non-Hispanic Black, and Hispanic. And we know, again, that to be true even post-pandemic. And what's the percent of pregnancy-related deaths from 2014 to 17? Cardiovascular conditions, sepsis, cardiomyopathy, hemorrhage, and even on, kind of the evidence-based protocol piece, we're not really even talking yet here about the behavioral health component, except for, down here. And it was super combined, so we had no specificity around that. But we know that everybody across the country is very focused on hypertensive disorders and hemorrhage and sepsis. And so those are things that we are very focused in on the acute care side. We know that mental health now, it's kind of finally made the headlines, if you will, around the leading underlying causes of pregnancy-related deaths overall by race, ethnicity. And again, from 2008 to 2017, I think the highlights here: non-Hispanic Black population, cardiovascular, cardiomyopathy were the leading underlying cause. But for the non-Hispanic white population, mental health was the leading underlying cause. And so you'll hear us start to talk about knowing your data, knowing your patient population. And that's why we have to expand the conversation to include this part of our skill set and awareness. So we want to take a poll here and ask for your participation. in what you think is the time period, and let me say it this, at what period in time after pregnancy is the highest rate of death for women? Is it 0 to 42 days, 43 to 150 days, 43 to 365 days post-pregnancy? So we'll take a couple minutes here to let you vote. And we'll wait here for, it's really interesting. When this data came out, that was kind of an aha moment for me as well. But again, it really starts to give us clarity on what we need to do in order to address this patient population. So it looks like we really have a pretty good equal distribution, with, I guess, the majority thinking from 43 to 365. And the drum roll, the answer to this is the 3 in 4 women die between pregnancy and the first 42 days. So it's really kind of an aha moment for us. Also, so just think about that for a second, let that sit in. What happens during that time frame from the time a person delivers and then that first 42 days, what's happening in that person's life? And imagine someone who already is not in a great position, is unemployed, doesn't have resources, etc. And there's some other factors here. Look at age at death. 47.9% age 15 to 19 years old also puts them at a high risk. Education absolutely matters. High school or less, they have a higher rate of death as well. So lots of opportunity for us to think through our patient populations and where we need to put some time and attention. This, I think, is really enlightening to me, when I'm consulting and I'm doing the work as to the critical factors among pregnancy-related deaths, system of care factors. And again, you're thinking about the system of care, where the patient is getting care. The CDC and the MMR team had access to a really unique data set. They had access to social records. They had access to any behavioral health or acute care records, death certificates. They really, turned every leaf over to look at this. And what they came up with, which I just think is fascinating and really informative, lack of coordination and patient management. Some of this stuff, I think we look at this, we're a little jaded because we always hear that, but it's like, what are we going to do about it? And now when we know we have a crisis and we're in terms of the highest maternal mortality rate in a country that spends the most in healthcare, something is broken here, and we really have to pay attention and peel the layers back to understand in our own healthcare organization, what does that mean? Lack of coordination, lack of communication between patient providers, behavioral health, social services, the pediatrician, the primary caregiver, the nurse midwife, the nurse, etc. A lot of opportunities there. On the provider factors, so this is hospital doctors, midwives, anybody that is, actually delivering care. Failure to perform clinical assessment. Wrong or delayed diagnosis, delayed in treatment. Lack of communication between patient and providers, lack of follow-up by providers. So when I think about our role in healthcare, this is what we are supposed to do and do it well. And keep in mind, this was before COVID. So things have been exacerbated with COVID, and we have some other things, that we're going to talk about, but I think this is really important. And then again, the patient factors. I think this is important because a lot of times people, tend to point fingers and say, she's not, she doesn't follow up. She doesn't go to her appointments. She's a very difficult patient, without really understanding the social circumstances around what might be some of those barriers to good and standard health care that we want to give these patients. Their absence of social support systems, inability to recognize the need to seek care, disruptive relationships and housing, lack of adherence to medication. So even though this may exist, it's upon us, our responsibility to start to address this, obviously in a different way than we have heretofore. Additionally, again, take this holistic view of a patient's lived experience. And of the 421 deaths from 2008 to 2017, 46 were attributed to mental health, with the distribution of high rate of suicide, high rate of history and current substance abuse, unintentional poisoning or overdoses. This is staggering to me. And again, that's at 43 days to 365 days. So you start to see the longevity of how long we have to stay engaged and really make sure, because, and I always say this, and I know Rola is going to have a lot to contribute here based on her expertise and experience, but where the mother goes, the family goes. And so if we don't stop to interrupt this cycle, we're going to continue on this, dreadful path that the data is already telling us. So again, race, ethnicity, education, health insurance, the clinical sources, the non-clinical sources, all contribute the social determinants of health. We have already talked about high school degree holders or less have a mortality rate 2 times higher than that of college degree holders. Lack of insurance is associated with a higher risk of cardiovascular, respiratory, and severe sepsis-related death, and in-hospital mortality. And non-Hispanic Black women, we know, we want to underscore this, highlight this, nearly 3 times higher the rate of non-Hispanic white women. I am excited to say that there is some action taking forward at the federal level. We'll talk about that here in a minute. But the things that, I say it this way, that were in the purview of our control and our domain to do, which, we've not been able to do well. Now there's going to be some federal mandates around that's coming. So, and we'll talk about that in a minute. So a little bit about peripartum depression and mental health. Rola, I think we will hand it over to you.
Fantastic. Thank you, Laura. We're going to start it off with a poll. So thinking about processes within your own organization, how often do you follow up with mothers that are at risk post-discharge? Do you follow up with all mothers post-discharge? You only follow up with mothers that have an identified risk factor for peripartum depression, or you do not follow up at all post-discharge? All right, let's start seeing some of those results. So great, it looks like the majority, 45%, follow up with all mothers post-discharge, which is great to see. I'm going to talk a little bit about some of my own clinical experience and the research around peripartum depression and mental health issues within the peripartum population. And so let's see, can I move forward? Okay, there we go. So let's talk a little bit about peripartum depression. We know peripartum depression is common, but it's still pretty seriously underdiagnosed. And there is, some research out there that suggests that the underdiagnosis might be erring on the side of caution, trying to differentiate, is this baby blues with all the changes in hormones and the addition of a new person to the family versus peripartum depression. But we're seeing with the concern around this topic, we're seeing more and more organizations talk about, you know, recognizing those symptoms of peripartum depression and screening more regularly so that it's not just written off as baby blues. Some of the things that are sometimes not recognized are that are, you know, indicative of peripartum depression are changes in sleep, appetite, and libido. And these are because there are hormonal and physiological changes that could be an explanation for these. However, these hormonal and physiological changes, along with increases in, you know, not enjoying things and feeling a sense of anxiety, those are directly connected to a possibility of a depression diagnosis. We know that screenings are not routinely implemented. And this can happen for a lot of reasons. A big part of it, and we'll talk about this in a minute, is burden on staff, right? When you don't have enough staff or when there are a lot of responsibilities on the staff, it can feel difficult to try to get one more screening in. And especially because when you're screening for any sort of mental health condition, your practice around screening needs to take time, be highly empathetic. And if you have staff that aren't comfortable or haven't been adequately trained, they may not feel comfortable doing these screenings, and so they may not happen. And then, of course, there's the stigma and the shame that will make mothers less likely to report. You know, it's common for mothers to not want to say they don't feel bonded to the baby, or they're having a difficult time, you know, making a connection or feeling happy around the baby. Those are things that cause stigma because everything in our society is tailored around talking about this bundle of joy and all the excitements of new motherhood. And, you know, having feelings opposite of that carry a huge stigma. We know, however, that peripartum depression increases the risk of suicide, impairs the long-term ability for maternal and infant bonding, and will not go away on its own. It needs to have treatment in order to go away. We also know that there's a significant economic impact of peripartum depression. And, you know, like Laura mentioned, under-resourced communities or communities, populations where there's more difficulty around some of the social determinants of health, they are going to struggle more with peripartum depression. And a big part of that is their access to economic resources that will help them get the care that they need. And so it's kind of this catch-22 that happens. You end up in this cycle where you can't get the resources you need, so you don't get the resources you need, your conditions get worse, but you can't get them. And then, you know, the cycle continues to grow. We know that when symptoms aren't handled properly on an outpatient basis, they increase the need for inpatient services and emergency department services, which are more costly to both health systems and the patient. Screening for peripartum depression has really become the standard of care. We know that, you know, at well child visits, that those infant visits that happen, that mothers should be screened as well, right? Because oftentimes they're more likely to show up for their infant's visit and, you know, take care of their infant's needs than their own. And so having an opportunity to provide screenings there is an excellent way to make sure that the mother is also receiving the care that she needs. And it has really become, you know, a standard recommendation from mental health professionals, you know, through, you know, obstetrics professionals. Again, you know, like we mentioned, screening is sporadic. It doesn't happen as frequently as it should. There's a lot of stigma still around screening. Mothers may not answer completely truthfully. And it's just not happening as frequently as it should be. And I will say, we'll talk about this a little more as we delve a little bit more into screening, but screening is not a one and done situation, especially when you're thinking about mental health issues, right? You know, in medical practices, they don't just check blood pressure once a year, right? They don't check, you know, if a patient has diabetes, they don't check A1C once a year. And the same goes for peripartum depression. If there is if a mother is peripartum, screening needs to happen more than once. Even if the first screening comes back at, a lower rate, consistent screening every month or every couple of weeks, depending on follow-up schedules, is recommended because symptoms could surface at any point within that first 4-month period. So taking a look at the Edinburgh postnatal depression scale, this is currently, the gold standard in how we screen mothers for peripartum depression. Just wanted to share this with you, an example of it for those who may not be super familiar with it. It's a possible 30 points. The higher the score, the worse the symptomology. So when you're looking at, if a patient has a 27 out of 30, we'll talk about this on the next slide, but that's indicative there's probably depression present. Question 10 assesses for suicide risk. This is a topic that I'm extremely passionate about. We cannot dance around this question. We have to ask it directly, asking about thoughts of harming oneself. And a good follow-up to this would be thoughts about harming the baby. Which again, it's a very difficult question to ask. I've spent years training new behavioral health clinicians on asking this. They don't want to make patients uncomfortable. They don't want to offend anybody. But the only way to get a truthful answer to this question is to ask it directly and, to reassure the patient that thoughts of being better off dead or thoughts of hurting oneself, they're common when depression exists. But there are ways to get help. And so just wanted to highlight, especially question 10. And so when we look at, what are some recommendations for intervening once you have the screening completed and you have the score. If you're looking at anything less than an 8, there's probably low risk of depression. Like I said, this is not a one and done because maybe you give this to the patient prior to discharge. You want someone following up within 2 weeks to see if symptoms have surfaced that weren't there before. But when you have a low risk of depression, psychoeducation tends to be sufficient intervention. When we're looking at scores between 9 and 11, that's moderate depression risk. And you would want psychoeducation, rescreening in 2 weeks, and connection to community services. This could be, services for group sessions. You may want to recommend therapy, even though you might not prefer them, or services to make sure that they have needs that aren't met, right? If there is, food insecurity or, they don't have a job, things like that. Those are ways to provide resources to the patient. When you're looking at scores between 12 and 13, that's in the high category. You want psychoeducation, you want rescreening in 2 weeks, you want further assessment, preferably a psychiatry consult or a behavioral health clinician, a licensed behavioral health clinician. You want a treatment plan before they are discharged from the hospital, and you want a referral to mental health services so they can continue to receive mental health services. When you've got a score greater than 14, you're looking at the probability that depression is present, and you need all of the above plus establishing continuity of care. Making sure that patient does not get discharged without knowing that they've got an appointment coming up with someone that's going to be able to do further assessment and make sure that the patient has access to resources and the patient's getting the services that they need. And then, of course, question 10 is suicide risk. If this question is positive, you would need to complete a full suicide risk screening and a safety plan. This is just as much for the patient's safety as it is for the organization's liability, right? We don't want someone who is showing positive symptoms of suicidal risk to walk out without being properly assessed. This does not mean they need to be, on a 48 or 72 hour hold. This just means that there need to be resources available to keep the patient safe. So talking for just a minute about, case management versus behavioral health. A lot of what I shared on the previous screen, especially within those first 3 boxes, a lot of that can be completed through case management. If you have social workers or nurse care managers who are responsible for case management, there's a lot that case managers can do. But we also know case managers tend to have heavy workloads, and that not all case managers are trained in behavioral health practice, right? Providing behavioral health services. And they're typically not responsible for diagnosis and treatment interventions. That really should reside with a behavioral health expert. And so one of the things to keep in mind when you're thinking about who makes up your staff, who your patient has access to, thinking about the incorporation of behavioral health consultants that are licensed clinicians, whether that's social workers, marriage and family therapists, psychologists, psychiatrists, someone who is responsible for assessing, diagnosing, intervening, and creating a treatment plan. That's really what needs to happen prior to discharge. If a patient is at moderate risk, high risk, or has a probable depression diagnosis. I've seen this integration happening a lot more in hospital systems. I've been part of that integration at a women and children's hospital in Texas, as well as a couple of cancer units. I've seen more and more of it happen. It's just not happening rapidly enough. And a big part of it is budgets. But with proper triaging and a proper workflow, this will add so much benefit to your patients to have licensed mental health clinicians be able to provide these services. One thing that licensed clinicians can add that case managers can also do, but really what licensed clinicians can add through this clinical lens is being able to understand these social determinants of health through the lens of impact on treatment and impact on outcomes. And so, here we've got the, 6 categories for social determinants of health. When we look at things like employment status or literacy or, lack of support systems, behavioral health clinicians, licensed clinicians, are trained to write those risk factors or those factors, into their treatment plans, right? A big part of behavioral health is social care, and that's where social determinants of health fall. And so having access to a licensed clinician who can ask about, neighborhood safety, right? Maybe that becomes an issue for a new mom who's getting ready to be discharged, and maybe there's neighborhood safety issues, or stress, trauma, being able to incorporate those into the treatment and understand how they're going to create an additional burden on top of the already existing depressive symptoms. So when we talk about screening tools, the reason I wanted to share those social determinants of health is because, a lot of organizations have gotten comfortable with adding some, screening tools into their assessment process. The Edinburgh, for example, is becoming more popular. PHQ-9 is really standard for assessing for depression. The GAD-7 is becoming standard for assessing for anxiety. But a couple of others that sometimes may get forgotten about, especially when you're looking at suicide risk, is the Columbia Suicide Risk Severity Scale. That's really a helpful tool for understanding the risk of harm that the patient is in, and helping to devise a proper treatment plan and safety plan for the patient. And then being able to assess for social determinants of health is critical, right? It's not just background information that we need to have on the patient. It really should be embedded into the treatment. And so when you look at, a tool like the CMS Accountable Health Communities health-related social needs screening tool, that's a mouthful, but it's a really fantastic tool that could be added to the workload of a licensed clinician. Say, let's talk about what's happening in the social factors in your life and how that might be impacting your treatment outcomes. one of the things that's really important when considering these screening tools is understanding the administrative burden that it's going to put on your staff and how some of these can be broken up amongst different staff so that this doesn't become a hurried process, that thoughtful and thorough screening is happening throughout the patient's stay, and that it can be connected to a thoughtful treatment plan. So a couple of just final thoughts, if you have behavioral health clinicians within your practice, some of the things that they should be, thinking about is understanding inequity and disparities, especially between highly resourced and under-resourced communities, like Laura mentioned earlier. Being aware of the assessing diagnosing practices. Are there standards for assessing diagnosing practices for behavioral health staff, like there are for your medical staff? Documentation practices. This is one that I see a lot in hospital systems, where behavioral health clinicians may not document in the same EHR as medical professionals, and if both teams don't have access to the same information, then the patient isn't getting strong continuity of care. And finally, making sure that intervention and treatment recommendations are based on professional standards and best practices. A quick run through of some of the treatment options that currently exist. We know antidepressants are effective for depression, and peripartum depression is a depression with a specifier, right? It's usually diagnosed as major depressive disorder with the peripartum specifier. So we know that antidepressants can be effective. Psychotherapy and antidepressants are the gold standard when we're treating for depression. Connecting to resources is one of the strongest tools that you can give your patients. When patients know where to go and the burden of figuring out where they need to go is taken away, they're way more likely to access the help that they need to get better. And finally, group therapy helps normalize the experiences that mothers may be experiencing postpartum season. And finally, just understanding a little bit about the gaps in mental health services within your organization. Understand the scope of the mental health and psychiatric services available. Expand the number of behavioral health clinics, whether that's those connected to your hospital or those that you refer to and have a partnership with. Increase training on mental health for all staff. We've moved beyond the point as a healthcare, field where we can talk about mental health and physical health as two separate entities. We can't do that anymore. All staff needs to be prepared to understand how mental health impacts overall patient health. And finally, like I mentioned, review your mental health documentation practices, making sure that behavioral health and medical staff are documenting within this. And with that, I will hand it over to Laura.
Thank you, Rola, for that. I loved what you said about, the gold standard in treatment, because I hear it all the time is, you're talking about a specialty, and with the change in, insurance and the goal to get patients through the hospital, if it appears to be uncomplicated or what can be managed outside of the walls of the hospital, that sort of thing. But that going back to training the healthcare team, the clinicians in the hospital, that they actually have to now kind of also take on that social aspect. And again, we know we have changes in there. So we're going to talk about that here in a minute. Very quickly, we're going to do another poll. And the poll is, do you have a list of community resources, referrals related to all the things we just talked about: suicide ideation, food, and clothing, substance abuse disorder services and resources to give with the mother at discharge? Yes, no, or unsure. And I can tell you, we have some data on this. It's pretty surprising how many hospitals some do it. Back to you, Rola.
Thanks, Laura. So this is a visualization of the model that I'm going to talk about a little bit more in the next slide. It's the collaborative care model, and it has been highly effective in managing depression. And so in this model, the patient is connected to both their primary care provider, whether that's their OB, in outpatient setting or another PCP, and a behavioral health consultant. It says behavioral health care manager here, but again, we're talking moving away from case management into actual clinical services. And then they actively exchange information in the EHR together. And then the behavioral health provider is responsible for escalating the situation if a psychiatric consult is required. Laura, if you'll go to the next slide, please. One of the things when we think about the collaborative care model that's really important to understand is it's both an evidence-based model and it's empirically supported. There's a lot of research to show the effectiveness and efficacy of this model. It talks about, it addresses the barriers for care up front. Some of these barriers where referrals are happening, but patients aren't being seen. This model, the collaborative care model, actively addresses that. And it has shown success in women's health settings, in multiple randomized trials, and it increases provider satisfaction and a patient's confidence in managing behavioral health problems. And so this is a model that's incredibly effective. And it's one that, as if you're thinking in the context of being a hospital system, if this is the model through which you refer out, looking for those organizations that have this model, or partnering with other organizations that have this model, patients have a better success rate with treatment.
Excellent. So the one piece I wanted to talk to you about very quickly, we're going to close out here, of what's coming from CMS and the designation of a birthing friendly hospital. So what the Health and Human Services through CMS is taking these steps. So the Biden administration has made a commitment to reducing and addressing maternal mortality and morbidity, and disparities, and understanding better these communities where these mothers are at the highest risk. So under this proposal, CMS would initially give the designation to hospitals that they have to do this attestation that yes, to maternal morbidity structural measure. And the measure is to attest to specific capture whether the hospital is participating in a structured state or national perinatal improvement, a QI collaborative, and implementing patient safety practices or bundles as part of these QI initiatives. So that's part one that is happening in 2023. Following that, there's more structure and more measurement going to be required if you're delivering babies. CMS is proposing the collection and screening of social drivers of health equity measures to perinatal CQMs, cesarean birth, and severe obstetric complications, and available for self-selection beginning in calendar year 2023, reporting period in fiscal year 2025, payment determination followed by mandatory reporting beginning with calendar year 2024 and 2026 payment determinations. So again, it's I've dropped the the link in, it's live in here that will take you to this announcement on key measures. And I would review this and talk about what is your plan from now to be ready to report this data, because what the government really, what we really want to know is where are the pockets of healthcare deserts, behavioral health deserts, high-risk communities, and what resources do we need to provide, and what can we all do to get better at this. So again, without saying, obviously the time to act is now. We went in summary, know your patients, know your data. What is the patient population you're serving? Integrate universal mental health screening and coordination of care into OB care. Take a closer look at that late postpartum period. Remember, women die between pregnancy and 42 days. That whole year is really important, but in that first time frame is very, very important. Know your communities and educate your staff. So with that, I think we may have just we're over time by 1 minute if anybody is still with us. And I don't know if we want to take any questions or we want to do a follow-up, Jen, but I will hand it over to you.
Yeah, thanks so much, Laura and Rola, for the great data and the great insight as to some of these trends and what the current state of maternal health is. So given that we are a minute over, I want to make sure that we do end, and we will be sending follow-up. So we'll provide as much information as we can in a follow-up email by the end of the week. So anyone who's registered for this webinar can expect to receive that from us. So once again, I just want to thank Laura and Rola and Relias for sponsoring today's webinar, and I hope everyone has a great rest of your day.
Thank you.